Well, ladies and gentlemen and everyone, my name's Julie McCrossan, and it's my pleasure to welcome you to this special interview about innovations in the treatment and care of head and neck cancer patients, and it's because it's Head and Neck Cancer Day 2022. And it's my pleasure to welcome Associate Professor Richard Gallagher. He's an ENT surgeon, ear, nose and throat surgeon. He leads cancer services and the head and neck cancer service at St Vincent's Healthcare Campus, Sydney. And we're going to talk about innovations in facial reconstruction and potential benefits to patients of the emerging 3D virtual surgical planning. So Richard, thank you as always for sharing your expertise with us. Just in a nutshell, can you tell us a story about a patient that has benefited from this new approach to facial reconstruction, particularly the planning, and in a way that illustrates why people may lose bone in the first place and need to have it replaced? If you could tell us a patient story.
A quick one is someone I'm going to call Jim, who back in 2018 had cancer in his neck and a lymph node in the neck, and we didn't know where it had come from. It was an unknown primary, and it was possibly came from skin. He then went on to surgery to remove the lymph nodes in the neck, so a neck dissection, and then he had radiotherapy treatment for that. And then he did very well, no problems at all, until about the middle of 2020, when he started to develop some pain and discomfort in his jawbone, and it became clear that he developed a problem known as osteoradionecrosis, or bone death, which sometimes happens, unfortunately, after you've had treatment, after surgery and radiotherapy. Can happen just with radiotherapy, of course. But this man, he had a problem with his right lower jaw. So I'll just show you on the model. So he had a problem here on his jawbone on this right-hand side, from near the front to halfway up the back here, which is a difficult thing to replace. And so we were able, using 3D virtual surgical planning, we were able to manufacture essentially a manufactured plate that was exactly the correct shape, and then fit it onto him, and then put bone from another part of the body into that plate to replace the jawbone. And so the big advantage for that patient was that he looked good. He looked like his old self. He was able to eat and drink normally, so he could chew. Admittedly, we'd taken away some of his teeth on that side, but there's the potential that he can have those teeth replaced and have dental implants at some stage. So it was really a great benefit to him. Previously, it would be often difficult to get this exactly right. Sometimes patients would have much more difficulty with their eating and drinking after the surgery, and also with their cosmetic appearance or the way that they look to the world.
Okay, and I just want to say, for people who are new to the world of head and neck cancer, you may be a patient interested in this issue. I myself have had head and neck cancer. I've had radiation to the jaw, and I have regular follow-up with a dentist who's watching out for that small number of people who can get the condition that Richard Gallagher is describing. And we have a series of videos about it, and we'll share a link to those videos. But coming back to this 3D virtual surgical planning that you've used with this particular patient, you've emphasised that it had an improvement in the way he could eat and drink, the function, that he looked better. It had advantages for his teeth and his dentition, I think is the word you use.
Yeah. And
is the essence of it too that you can be very precise? It's almost a kind of customising to the individual patient. That means when you do take bone from elsewhere in the body to help with the reconstruction, you don't have to take as much. Can you tell us a bit about that benefit?
Yeah, so it means that you're actually manufacturing a replacement for that individual patient. So for you, the patient, and it's not a one-size-fits-all picture. So you can replace that piece of bone with bone from another part of the body and be much more precise about the amount of bone that you use and how quickly you might be able to actually get that to take that bone and put it into the jaw and reconstruct it. So it has a whole lot of implications. It increases the speed of surgery. and it actually makes it easier for the surgeons because it's much more precise and there's not a lot of messing around trying to work out whether it looks good or doesn't look good, because you've actually manufactured it for that patient beforehand.
And where do you get the bone from that you use as part of the reconstruction?
So typically for the lower jaw, so the mandible, the lower jaw, typically we get that from the fibula. So that's in a bone in your lower leg. So that's where we get that one. And also don't forget that there's the upper jawbone, your cheek or your maxilla. And you can use fibula, the same piece of bone from the leg, or you can also use some bone from the shoulder blade, or called the scapula, is also used as well.
Let's talk about some of the barriers that can make this innovation not accessible to patients, because it's not everybody that can benefit from it. You mentioned that one of the advantages is you've mentioned the importance, I think, of being fast in the treatment of cancer, but some people have cancers that are so aggressive, there may not be time to use this approach. Is that right?
Yes. My experience has been, and I think the others are the same, is this technology is evolving. It's been around for a while now, but it's getting better and better. And the amount of time that it takes to actually go from the planning process through to getting the material or the plate to do the operation and what we call surgical guides it really does take 2 to 3 weeks. And that may be too short. That may be too long for some patients, unfortunately, if they've have a particularly aggressive cancer. And you might have to consider that you do something else initially, and later on you can come back and do some more complex reconstruction if you need to. So that's a problem that we might have to face. But a lot of the time, most of the time we've got that window period to work with. The other thing is that it's expensive, and it does cost a lot of money. There's a certain number, a lot of people, different people involved in the process. It's a game. It's about multiple members of different teams working together to make things happen. But it is expensive, and it's expensive both to the whole health system. In Australia, the private health funds do tend to cover these systems so that we can do virtual planning. In the public hospitals, some of the public hospitals I know are prepared to pay for it for patients, but I don't know all of those hospitals which can do it at the present time. But I think that over time, of course, as it becomes more common, it'll become cheaper and it'll become more readily available, and it'll become faster to be able to manufacture these things.
But in a nutshell, right now, it's not available at all cancer centres, and there isn't at the moment a sort of a public register telling you where it is available. So if someone's watching this and it really matters to them, they need to talk to their ear, nose and throat surgeon about whether it may or may not be a possibility.
Yes, that's right.
Okay. And, you mentioned it's a team is involved, and I guess, again, for the uninitiated with World Head and Neck Cancer Day, this very much is a multidisciplinary team world, isn't it? And that includes, with this 3D virtual surgical planning, you're using a team before, during and after the surgery.
That's right. I mean, there's let alone the technical things about the operation itself, planning, which is going to involve the surgeon who might be removing the bone, and whether it be a benign or malignant tumour, or it may be a bone death problem. There's the reconstructive surgeon. Then there's the scientists and people who are involved with doing the planning, which is typically done online by computer planning. And then once that's all been done and you go to theatre and you put everyone, you do the operation, you put patients back together and things, then there's all that stuff happens afterwards again, that patients are going to go through a period of time where they can't eat and drink, so the dietitian's involved for feeding, the speech pathologist then becomes involved. But these things all happen and much quicker, and it's much more precise using this virtual surgical planning technique.
Look, it's been great to speak to you, Richard, and we'll let people know that we do have a series of videos we've made together last year for World Head and Neck Cancer Day, all about dental issues, and we'll give you a link to that. But in a nutshell, if you've had radiation to this part of your body, make sure you tell your dentist so that they can watch out for that rare number of cases where this bone death that we've described can occur. But I want to wish you a happy World Head and Neck Cancer Day. I know that sounds odd, but I say that because people like yourself and your team are working for a better future with innovations such as this. So Associate Professor Richard Gallagher, thank you. And Richard, of course, is an ENT surgeon at St Vincent's Health Campus, Sydney. Thank you very much, Richard.
Thanks, Julie. Thank you.